مساء الخير على حضراتكم. كل اسوارز وانتم طيبين وبخير. طبعا يشرفني ان انا اقدم برزنتيشن على الكاتراكت سيرجري اند اوكيولار سيرفيس ديسيزز. ويمكن هتلاقوا في المؤتمر السنه دي في كلام كتير على الاوكيولار سيرفيس ديسيزز وعن الدراي اي، لان بقى ده موضوع very essential وموضوع مهم جدا بالنسبه لنا، وهنكتشف ان هو في الديلي براكتس بتاعنا لازم نبقى مهتمين بيه كويس قوي، لانه في بيشنتس كتيره ممكن يبقوا ميست وما بيبقاش عندنا explanation واضح للسيمتومز اللي عندهم especially after cataract surgery and LASIK، وبيكون التفسير هو ان هو احنا ما شخصناهوش كويس او ما حددناش الاوكيولار سيرفيس stability بتاعته شكلها ايه. يمكن سريعا، انا مش عايز اطول على حضراتكم، لكن dry eye هي the most common and potentially most devastating complication of cataract surgery that can affect patient comfort and visual outcomes of the procedure. نبقى عاملين cataract surgery perfect ونفاجئ ان البيشنت برضه still complaining، وبنبقى مش عارفين نتصرف ازاي. Dry eye disease is a complex زي ما احنا عارفين و debilitating inflammatory condition of the ocular surface. Worldwide epidemiological studies بتقول ان ال dry eye diseases prevalence ranges from 5 to 50% of patients. يعني ممكن نصل ان 50% of patients they suffer from dry eye. لو ترجمناها الأرقام يعني ممكن يوصلوا 3.7 billion of people suffering of dry eye all over the world. Dry eye disease increases with age. This is a common fact, with the prevalence of the condition rising steeply starting from the age of 50 years old. Through limiting participation in working life and daily activities and increasing healthcare costs. Preoperative dry eye is present in 60% of cataract patients. The statistics بتقول كده, though in some of them might pass asymptomatic. 1 month after surgery, the rate increases to 87%, and these percentages are greater than those of LASIK. يعني in cataract surgery بتبقى أكتر من الليزك. في other studies بنلاقي إن post-operative dry eye signs and symptoms peak at 1 month and persist for at least 3 months, with longer duration for patients with pre-existing dry eye. Patients who presented for cataract surgery في study تالتة بيقول إن 60% had abnormal tear breakup time, and 46% had central staining, and 18% had Schirmer's test score at or below 5 mm. كلها أرقام تهمنا جدا. طب ليه؟ Why? What are the reasons for dry eyes after cataract surgery? Cataract surgery patient population usually are older and has a higher incidence of preoperative dry eye than younger patients زي ما قلنا. دلوقتي معظمنا بيستخدم ال premium IOLs and multifocal IOLs, وده بيبقى denoting in these patients usually engage in situations contributing to ocular dryness, computer using, mobile using, and outdoor activities. Problems related to dry eyes are magnified by the inherent decrease in contrast sensitivity with the lens types, especially the multifocal. عندنا فاكتور تاني, surgically induced ocular inflammation adversely affects patients' tear film production and stability. Pre and post-operative topical medications, كلنا بنستخدم pre-operative and post-operative medications with preservatives that may affect the goblet cells. Another factor contributing to the cause of dry eye after cataract surgery, especially the cataract incision, the limbal relaxing incisions. Some of us use the limbal relaxing incisions. This leads significant corneal anesthesia and dry eye. Some patients need enhancement, excimer laser enhancement rate, which ranges from 5 to 10%, especially with the multifocal and the different types of IOLs. So the risk of dry eye disease increases from multiple surgeries done. Let's imagine, خلينا نتخيل, you gather a group of patients who are prone to dry eye syndrome due to their age and coexisting systemic health issues, and now you cut the corneal nerves through the corneal incision, and you create some inflammation and induce some inflammation, and then induce more ocular surface disruption via topical pharmaceuticals. خلينا نتخيل, is there any wonder why these patients complain of dry eye and ocular irritation and foreign body sensation, especially after surgery? We have to put in mind all these points and these factors. For preoperative assessment for cataract patients, we have to do thorough ocular history. If the patient is a contact lens wearer, is there any contact lens intolerance, foreign body sensation, grittiness, record of ocular symptoms that worsen later during the day, fluctuation in the visual acuity, and then we have to do what's called ocular surface stress test in every patient before surgery. We do local anesthesia to measure the intraocular pressure. We do vision testing. We do mydriatics. We apply mydriatics for fundus examination. And then please re-examine the patients after the usual waiting period for any irregularity in the epithelium or punctate keratopathy that may be discovered after doing these stress tests done during the routine examination of the patient. The basic knowledge, all of us know that we have to do diagnostic approaches to dry eye, assessing the corneal sensitivity, Cauchy-Bonnet esthesiometer, Schirmer test, tear meniscus evaluation, tear film osmolarity, the tear protein analysis, meibomian gland assessment, and dye staining either with lissamine or fluorescein or rose bengal, and tear breakup time. When using the lissamine green, we have grading as we see here. The grading ranges from grade 1 to grade 4 according to the stain area, either in the nasal conjunctiva, nasal and temporal, staining in the nasal and temporal plus the inferior corneal staining and the corneal staining in the central area. These are the grades, and we have to document that and to mark it. We have what's called ocular protection index. Ocular protection index measures, we have to interpret the interaction of the time between the blinks, or what's called the inter-blink interval, and tear film breakup time. Measuring both of them helps to regulate the integrity of the ocular surface. ونهتم بكلمة integrity of the ocular surface, which is very important. نرجع تاني, we have older age, especially female gender, decreased corneal sensitivity. Some of the patients have floppy eyelids, leads to ineffective or decreased blinking. Sometimes we have allergy, atopy, rosacea, or meibomian gland dysfunction, leading to mucosal inflammation and edema. medication toxicity, all leads to ocular irritation, and even the post-operative drugs, some drugs leads to medicamentosa and drug-induced ocular surface sensitivity. We have to diagnose a very important sign, which is called lid parallel conjunctival folds, Lipkoff sign. زي ما احنا شايفين كل الصور بيبقى فيها grading of the conjunctival fold either from 0 لحد لما بيبقى عندنا what's called conjunctivochalasis. We have to report that. So the pre-operative assessment عندنا الجدول الطويل اللي احنا شايفينه ده starting from the symptoms, from the signs اللي موجودة اللي احنا قلنا عليها, and we have to document all these points عشان نوصل عايزين نوصل له اللي هو Ocular Surface Disease Index OSDI. هو عبارة عن مجموعة from the questions, and we encircle the number في البوكس اللي فيه representing the answer, and after that we collect the numbers and we can assess the severity of dry eye disease in these patients. كلنا كنا بنعمل التست دي separately. دلوقتي بقت كل ده بيتعمل in one step. ممكن تتعمل electronically بجهاز يقدر يقيس الكلام ده كله, وبتطلع الريبورت اللي حضراتكم شايفينه قدامه starting from the tear height, التير فيلم rupture film reference, الليبيد لاير, يشوف الميبوميان جلانز is it normal, وعندنا الريفرنس بيكتشر اللي موجوده فوقيها, الاي ليد مارجن and the condition of the lid margin شكله ايه, the redness and the distribution of the redness all over the eye, the tear film breakup time, the blink quality itself, and the ocular surface staining, and all these are reported in one report. You can assess the patient pre-operatively and post-operatively. Just to revise, احنا عندنا ocular surface diseases, either the dry eye, the dysfunctional tear syndrome, the allergic disorders, meibomian gland problems, and ocular immune responses. Treatment usually in the form of the lubricants, the anti-allergic treatment, the topical steroids, cyclosporins, and sometimes the tear duct plugs, lacrimal plugs, and sometimes we can do surgeries for the eyelid to do the modification. So we have to reach a point called optimizing the ocular surface. Pre-operatively, doing this optimization improves the outcomes of cataract surgery by decreasing the post-operative dry eye, promoting faster visual recovery, making keratometry more reliable, and therefore IOL power calculation will be more accurate, improving the wavefront evaluation in case the patient needs additional refractive surgery, and post-operatively there may be a reduced risk of infection, and the patient may be more comfortable and the healing is faster. Artificial tears, as we all know, in cases with severe dry eye, we apply the non-preserved tears at least 4 times per day. In mild dry eye, transiently preserved tears, and in very mild cases, we can apply the preserved tears. Gels and ointments are used overnight, and sometimes the nutritional supplements like the omega-3 may be beneficial for these patients to reduce inflammation. We have different forms of the artificial tears. Some are cellulose derivatives and some are hyaluronic acid derivatives. Concentration on these points, especially on hyaluronic acid and its importance, but we have to focus that the preservative is called vanishing preservative. It includes what's called sodium perborate. When instilled into the eye, it combines with the tears and then it decays into water and oxygen, which are the human tears components. So we avoid the side effects and the complications of the tears preservatives, specifically as if it is a preservative-free eye drops. Hyaluronic acid, as we all know, is a naturally occurring glycosaminoglycan commonly used in the treatment of dry eye. اديني آخر سلايد بس. It binds with the epithelium of the cornea and helps re-epithelialization of the corneal wounds, long-lasting benefits of the clinical use due to mucoadhesive and viscosity properties. Some studies were done comparing and in a randomized single-centered study the effect of using sodium hyaluronate for 3 months after doing bilateral LASIK. Showed a rapid improvement in fluorescein staining and improvement in the symptoms of dry eye. And the patients gave a satisfactory result after using the hyaluronate specifically. We have 2 concentrations, either 0.1 or 0.2. 0.2 is commonly used and it gives a very strong and very rapid effect, especially with cases with keratitis and keratoconjunctivitis. The impact of 0.1 sodium hyaluronate and 0.2 sodium hyaluronate artificial tears in the post-operative discomfort following cataract surgery were studied, and there were a significant difference and improvement after using 0.2 sodium hyaluronate artificial tears medications. We have to know that our modern day cataract surgery patients are very much refractive surgery patients. They expect great unaided vision immediately after surgery. Even if our IOL calculations are spot on and we eliminate the patient's pre-existing astigmatism, a dysfunctional tear film will significantly limit the post-operative visual acuity and satisfaction level of the patient. An evaluation of the ocular surface is one of the most important aspects of pre-operative routine for any patient who is considering premium IOLs. Dry eye can significantly compromise patients. Identify patients at risk, maximize the tear film stability pre-operatively, and design a surgical and intraoperative plan to minimize dry eye, and then use post-operative therapeutic intervention to minimize the symptoms. Thank you very much.
شكرا جزيلا دكتور